All right, so welcome to our CED Ability Grand Rounds series for June. We are excited about this presentation. It's a great way to finish up as we were talking about, summer already for this series. I do want to. My name's Leslie Cottrell, and I'm one of many on this call who represents the Center for Excellence in Disabilities. And so just really quick, everyone has used Zoom, too much perhaps, but just remember to mute, but feel free to ask questions, use the chat. We welcome active participants. It helps, it helps really soak in that information. So please feel free to do that. Closed captioning is available. Please let us know if you have any issues accessing that. And I think with that, we'll move forward. And I have the privilege to introduce Dr. Iezzoni. Dr. Iezzoni has spent more than 3 decades. I'd like to tell you a little bit about her. Conducting health services research. And this research focuses on 2 primary areas. And that one is risk adjustment methods for predicting cost and clinical outcomes of care, health care experiences, and outcomes of persons with disabilities. So she spent 16 years as co-director of research in the Division of General Medicine and Primary Care at Boston's Beth Israel Deaconess Medical Center. She later joined the Institute for Health Policy as associate director in 2006 and served as director of the newly named Health Policy Research Center from 2009 to 2018. Her bio we can provide in the chat. There are numerous grants and scholarly work in the area of the area she's going to be talking today in particular. And so we'll include that, but I want you to get a chance to hear about her work from her voice. And today you can see she's talking about physicians' attitudes and disability disparities. So with that, Dr. Iezzoni, I'm going to hand it over to you and welcome. Thanks for joining us.
Hi, I'm so delighted to be here with you virtually from my home just west of Boston, Massachusetts. So I know I'm preaching to the choir, but I'll give you just a few little introductory slides. There are 1 billion people worldwide with disability, and the numbers are growing. There's about 61 million Americans, or 26% of adult Americans with disabilities, and the numbers are growing. There are increasing numbers for various reasons, such as people like me, aging baby boomers with complex chronic conditions and comorbidities that tend to increase disability rates. We also see infants and children who would previously have died from congenital or early onset conditions now living into adulthood and middle age. We also have seen that the obesity epidemic that has hit young people is showing increasing evidence of early disability relating to diabetes and arthritis. And so that's a trend that will probably also continue. This is the cover of the book called Future of Disability in America that was published by the Institute of Medicine in 2007. And it made the point that disability touches virtually everyone. It's not a minority issue. It affects today, or will affect tomorrow, the lives of most Americans. So given that, why is it so hard to make healthcare fully equitable and accessible to people with disability? Why in 2021 do people with disabilities still confront barriers and experience disparities in their healthcare and health? So this is a picture of an elephant, and it is not a political comment. I just show it because I like the 2 metaphors that come with an elephant. You know that if you touch the tusk of the elephant, you know about the tusk, that if you touch the tail, you know about the tail. You can't know everything about the elephant unless you look at the entire elephant. So it's just a metaphor for the fact that disabilities are incredibly diverse. I myself have had multiple sclerosis for 44 years, and I've used a wheelchair for 33 years. So I know a lot about mobility impairment. And so you're going to kind of feel a little kind of undercurrent of mobility disability in virtually almost everything I say. But I just want to emphasize this point. And then the other metaphor with elephants, of course, is that disability is often the elephant in the room, something that you cannot avoid noticing, but a lot of people still in 2021 don't want to talk about. So I'm going to try to do 4 topics today. First is I'll give you like a couple slides on disability epidemiology, then talk a little bit about disparities. I'll then talk about a physician survey that I've been privileged to have led that has just recently, within recent months, come out with results. And then finally end with a case study about Michael, about the consequences of these physician attitudes. Okay, quickly, disability epidemiology. So this is a slide that shows numbers that we calculated from the National Health Interview Disability Survey for people ages 18 and older from 2000 and then 2011. These data are just a little old, but I think the trends still apply. And what it shows is that increasing rates of disability from one decade to the next. And then the fact that movement difficulty is by far the most common disability type, with about 23% in 2011. Followed by social role limitations or self-care or other social roles, about 14%. And then in decreasing numbers from sensory disability to mental health to cognitive difficulties. So again, disabilities are diverse, but about 26% of the population. This slide shows a graphic about the percent of the numbers of people ages 65 and older and 85 years of age and older from 1900 to 2050. And what it basically shows is that about the year 2000 or slightly after, all of a sudden, the number of people ages 65 and over just kind of took off like a bit of a rocket ship. And so these are the people that are going to be coming forward to increase the numbers of people with disability over the next few decades. But we also have younger people with disability that might not be apparent. And this is a cover of Newsweek from a few years ago, talking about showing a young guy holding his hand to his ear, suggesting that maybe he was burying his earbuds in his ears and had the music cranked up a little bit loud. And so maybe developed early onset hearing loss because of that. And then this is just a word kind of a chart that, or a word graphic that shows you about mental health disability, which is the second leading cause of disability for Social Security, entitlement for disability. And I just want to underscore the fact that different mental health conditions are highly prevalent among disability types. Okay, now on to disability disparities. So we know from NHIS and other work that people with disability on average are disadvantaged by the social determinants of health. Now, obviously, there are going to be people who are exceptions, privileged people like me, who has as many wheelchairs as I want to because I can afford them. But for other people who don't have that advantage, they might face even greater impediments to living a full life and participating because of social determinants of health: low incomes, low education, high unemployment rates, poor housing, inaccessible housing and or housing insecurity, significant transportation problems, food insecurity. And I just want to emphasize here that domestic violence is prevalent at higher rates among people with disability, including intimate partner violence and caregiver abuse. And we always start talking about domestic violence and intimate partner violence in terms of women experiencing that, but for people with significant disability, that can also happen to men as well. And so it's something to just keep in mind. We also see a strong intersectionality between race and ethnicity. Disability rates are 24% for whites, 30% for Black Americans, 31% for Hispanics, 16% for Asians, 25% for Native Hawaiians or other Pacific Islanders, and 40% for Native Americans or Alaskan Natives. So you can see a wide range of disability rates across race and ethnicity. The next few slides just look at some risk behaviors or health risks that also kind of disadvantage people with disability. And the red bars are people with disability, the blue bars are people without disability. And as you can see on this slide, at all age groups, 18 to 44, 45 to 64, people with disability have much higher rates of obesity than do other people. At all age groups also, again, red bars are disabled, blue bars are non-disabled. With the exception of age 65 and older, people with disability have much higher rates of tobacco smoking, which again is associated with a lot of comorbid conditions like heart disease and cerebrovascular disease. And we find that this is also a health risk behavior that is very dependent on the disability type. People with mental health disability have especially high rates of tobacco use. And people with disability are also a lot more likely to report fair or poor health. For example, at age 65 plus, 37% of people with disability report fair or poor health compared to about 7% of people without disability. But whenever I show this slide, I always like to turn it upside down and focus on the fact that even for people who are 65 and older, if you turn it upside down, this means that more than 60% of those people are not reporting fair or poor health. And so we have to remember that the vast majority of people with disability, even in the older age group, do not report fair or poor health. This is the cover of Healthy People 2010 that came out in the year 2000. And it was the first of the decennial Healthy People initiatives that are run by the U.S. Department of Health and Human Services to look at what the public health initiatives should be to improve population health in the decade ahead. This was the first volume, again, came out in 2000, that identified people with disabilities as a disparities group. And they attributed these disparities partly to erroneous assumptions about the daily lives, values, and expectations of people with disability. For example, common misconceptions that contribute to troubling disparities, especially in an underemphasis on health promotion and disease prevention. This is the cover of Healthy People 2020, which came out in November of 2010. And Healthy People 2020 actually had a focus on social determinants of health. And so when they were looking at what you need to do to improve the health of people with disability, it focused on things like employ people with disabilities, give them higher education rates, make their housing more secure and more accessible. So the next few slides are just talking about some of these disparities, and these are from some numbers that we calculated using the National Health Interview Survey. And this first slide is about PAP tests. And as you'll see, there are 6 different bars, and each bar represents a different type of disability. And people without disability have the highest rates of PAP tests at 85%. All the way down to about 68% for people with self-care limitations. As you can see, between that 85% and 68%, the rates of people getting PAP tests vary across disability types. But we also had the capacity with the NHIS data to look at the severity of mobility disability. And so what I wanted to do was to see whether increasingly severe movement disability related to lower rates of TAP tests. And in fact, that is what happens. So as you can see on this slide, there's a monotonic decrease in the rates of TAP tests as mobility disability increases in severity. And then this is just a slide about mammography. And again, it shows you that women without disability have much higher mammogram rates than women with self-care limitations. They have the lowest rate, and the rates vary slightly across disability types between those two ends. Okay, so I've also done a lot of work on breast cancer and disability. And so the next few slides are just some slides from a couple different data sources about breast cancer. And so I did both a study that involved interviewing women with major mobility disability who later developed early stage breast cancer, and then I'll show you some numeric slides in a second. So the first slide says that Mrs. Shannon, and this is a pseudonym for a woman who I interviewed in her home, she had had polio as a child and was now in her late 40s, early 50s. She had to use a vent to breathe because of the polio, but she had, kind of led a full life despite that level of disability. But when she went to see her primary care physician, that primary care physician had always examined her as she sat in her wheelchair. And she unfortunately had developed ulcerative colitis, and so she had to see a gastroenterologist. And it was the GI doctor who found her breast lump because to do a good belly exam, you have to actually get the person up on the exam table. And so her gastroenterologist always did that. And so fortunately, the gastroenterologist went a little bit north of her GI tract and examined her breasts and found the breast lump. So this is some data from the SEER Medicare data. And so SEER is the surveillance, epidemiology, and end results cancer registry data that is compiled by the National Cancer Institute. It represents about 14% of the US population, cancer registry data, and it has all sorts of interesting data about the cancer itself and about demographics of the people with cancer in the registry. And about 20 years ago, Medicare claims data were merged with the SEER data. And so if you started hearing about 20 years ago about disparities in care for racial and ethnic minorities with cancer, all of that comes from the SEER Medicare data. But if you looked at any of those articles and looked at the methods section, they would always say, the first sentence would be, we eliminated people under age 65 from the data. And of course, as you probably know, about 14% of Medicare beneficiaries are under 65 and are eligible for Medicare because of disability. And so all the prior work using Medicare SEER data until we came along had looked only at the 65 plus population. So here what I'm doing is looking at the population under age 65. And unfortunately, the SEER data do not tell us whether people have a disability. But what we were able to know, because we had the merged Medicare data, is that they were on Medicare. And the only way that under 65 you were going to be on Medicare was if you had a disability. And so looking at the stage 1 breast cancer, we had 97,511 non-disabled people within this data set, and we had 2,800 people with disability, i.e. people on SSDI who then got onto Medicare. And what you can see here is that the patient population with disability had a much higher rate of mastectomy rather than the breast conserving surgery of lumpectomy. So 45.7% of disabled women got mastectomy compared to only 38% of non-disabled women. And we were able to control for all the nifty kind of cancer-related variables in the SEER Medicare data set to come up with an adjusted relative rate. And what we found is that women with disability are 24% less likely than non-disabled women to have breast conserving surgery when they have stage 1 breast cancer. Now, okay, so why would women with disability have much higher rates of mastectomy? We don't know from the merged SEER Medicare data. We just don't know. But that's why I wrote this little grant and got to talk to women with disability. And so from having talked to women with disability who had early stage breast cancer and used a wheelchair, I started to get some clues. And one of the clues was that some of their doctors just thought that the women wouldn't care about their breasts anymore if they had a disability, and they'd be happy to have them taken off if they happen to get stage 1 breast cancer. And so here's kind of so if you're a qualitative researcher, kind of cover your ears, close your eyes about what I'm going to say, because I'm definitely leading the interviewee here, but I just wanted to make sure that I understood what the point that she was trying to make. And so I said, do you think that the surgeon thought that because you're disabled, that it wouldn't matter to you about your breast size? And she said, yep. And I said, that's what you think? And she said, yes, absolutely. Okay, however, for women with early stage breast cancer, getting a lumpectomy is equivalent in terms of disease-free survival to getting a mastectomy, so long as you follow that lumpectomy with radiation therapy. And so we were able, using again the SEER merged Medicare data, to look at whether people had radiation therapy. And what you can see on this slide is that women with disability were 17% less likely than other women to get radiation therapy after a lumpectomy. And that suggests that they actually got worse quality of care because they need to get this treatment after the lumpectomy to have the same disease-free survival. So again, why might women with disability not be getting the radiation therapy? So going back to my interview study, this is a woman who I'll call Sue, who had cerebral palsy, and she had had a lumpectomy and then needed to go for XRT for, the obligatory 8 weeks or whatever it was in her day. Um, and she had to get up onto the table for the XRT, and they had a Velcro strap to strap her onto the table so she wouldn't move. But she had the kind of uncontrollable arm movements that some people with cerebral palsy have, that her arms can often be at rest, but especially when people are ordering her to do things, her arms get less at rest. And they did not have any Velcro straps to control her arm movements. And so what they ended up doing was using masking tape to tape her to the table, the XRT table, every day. And so you can well imagine that if women realize shortly afterward that they're not going to be able to get accessible XRT, that they might just not get it. And these are the adjusted hazards ratio for mortality for women by disability. And so numbers that are over 1 indicate that women with disability have much higher mortality rates than other women do, than non-disabled women do. And of course, all-cause mortality is going to be higher for these women because, after all, these are all women who've gone through Social Security disability screening. They've proven that they have a disability that will prevent them from working for at least a year, that's caused by some medical condition. And so, as you can see on this slide, women with disability have much higher all-cause mortality, but you can also see that they also have higher cancer-specific mortality. For example, their overall cancer-specific mortality is 29% higher. And for stage 1 cancer, it's 45% higher. And again, we don't know from these data whether that's because they weren't getting the XRT, the radiation therapy, but it certainly could be. That's a hypothesis. Okay, so I am going to talk now about our physician survey. So previous research, including mine, has involved surveys of people with disability, focus groups with people with disability, in-depth interviews. I've probably conducted well over 200 with people with disability, which have suggested explanations for why we see these disparities. And these explanations are diverse. We know that people will often have complex underlying health conditions that might compete with whether they want a pap test that year. We also know they have disadvantages in social determinants of health, as I've said. There might be differences in patients' preferences for care, but I suspect that isn't driving why so many women with disability have mastectomies compared to lumpectomy. We know that there's inadequate training of healthcare professionals, that there's ineffective communication accommodations. We also know that there's inaccessible medical diagnostic equipment, including weight scales and exam tables. We know that doctors, or we hear that doctors have inadequate knowledge about ADA mandates for equitable care, but they also make erroneous assumptions about people with disability and have ableist attitudes about people with disabilities, their patient population. So several studies have examined physicians' attitudes, but typically these have been small studies that have been within limited geographic regions or specific institutions. So we were brave and we applied to National Institutes of Health for funding to do a national survey of physicians. And we, in fact, were fortunate enough to get funding from the Eunice Kennedy Shriver National Institute of Child Health and Human Development, for which we're very grateful. And this is the first ever national survey of practicing physicians and their experiences with and perceptions of caring for people with disability. And because it was the first survey and we wanted to get good response rates, we tried to cover wide-ranging topics, but we needed to keep the survey relatively short. So, and I'll say this multiple times, we went shallow, not deep. We asked a lot of questions, but we didn't ask follow-up questions. And the results that I'll talk to you here this afternoon are about physicians' perceptions. And if you want more details about these results, we published these in the February 1st, 2021 issue of Health Affairs. I'd like to thank our research team, my colleagues at Mass General Hospital, Sonia, Karen, Nicole, my colleagues at University of Colorado, Anschutz Medical Campus, Eric Campbell, Julie Esselum, University of Massachusetts, Boston, Dragana was our Crackerjack survey scientist who led the survey administration, and then my colleague Tara Legou, who was at Bay State Health, but has just been moved to Northwestern, where she's taken a wonderful leadership position at the program there. Okay, so we looked at physicians within 7 different specialties: internal medicine, general internal medicine, family practice, rheumatology, neurology, ophthalmology, orthopedic surgery, and obstetrics gynecology. We were limited in the number of specialties that we could look at because of our budget. To develop the survey, we conducted in-depth I conducted individual interviews with 20 practicing physicians. I won't blame anybody else for that. And then we also conducted 3 focus groups with 22 physicians total across 17 states nationwide. We use these individual interview findings and focus group findings to identify key topic areas for the survey and decide the survey iteratively, every other week, back and forth, telephone calls and Zoom calls. And Dragana and her group conducted 8 cognitive interviews and 5 pilot tests of the draft survey. And the final survey has 8 modules with 75 questions. Again, it's broad, but not deep. And if anybody wants a copy of the survey, I'm happy to send it to you. Just, let me know your email and I'll email it to you. Okay, so in terms of conducting the survey, we randomly sampled practicing physicians from a national list. We eliminated trainees, VA physicians, locum tenens physicians, physicians no longer practicing, et cetera. We sampled 350 physicians in each of the primary care specialties and 140 physicians in each of the 5 other specialties for a total of 1,400 in the sample. And the Center for Survey Research mailed paper survey in October of 2019 with a crisp $50 bill inside, because physicians will not answer surveys unless they're paid. So we had to pay them upfront. We also offered the option to answer the survey online. So CSR had information to track non-respondents, so they made follow-up phone calls and remailed the survey. We got into a little bit of trouble because we were doing the final kind of follow-up stuff when the pandemic really hit. And that actually complicated some things with our follow-through. And so we ended up having to close the survey in June of 2020. But we got 84% of our respondents responded by mail. Only 16% chose to go online to return the survey. The overall weighted response rate is 61%, which is considered extremely high for doctors. And the response rates vary narrowly across specialties, from 58% for neurologists to 63% for rheumatologists. So there are many findings on various topics, and I'm going to focus here on physicians' perceptions of caring for people with disability and on their knowledge about the ADA. So, all right, the main perception findings are that 82% of physicians report that people with significant disability have overall worse quality of life than other people. Need to pause there for that to sink in a little bit. Okay, so 82% think that people with significant disability have worse overall quality of life than other people. 41% of physicians are very confident in their ability to provide equal quality of care, only 41%. And just 56% strongly welcome people with disability into their practices. We did some multivariable analyses of the quality of life finding and found only one really statistically significant finding, and that is that women physicians are much less likely than men physicians to report worse quality of life for people with disability, with an odds ratio of 0.58. Safety net physicians, or physicians who had 35% or more of their patients with Medicaid or uninsured, were less likely than non-safety net physicians to report worse quality of life with a 0.59 odds ratio, but that was at a p-value of 0.06. So I'm cheating a little bit there to bring that one in. We also did multivariable analyses about whether physicians welcome patients with disability into their practice. And we found really high odds ratios for women physicians compared to men, with an odds ratio of 2.29 for women physicians being a lot more welcoming than men. Some racial and ethnic some racial and ethnic differences, but I don't want to show them to you here because our numbers were too small for me to really feel that the findings are rigorous enough to feel comfortable with reporting broadly. Older physicians have much less welcoming attitudes than younger physicians, with 0.58 of older physicians strongly welcoming people with disability into their practices, and physicians in private practice were much less welcoming than physicians at teaching hospital with an odds ratio of 0.38. So physicians who value understanding patients with disability were also much more welcoming than other physicians with an odds ratio of 5.46. And physicians who feel very confident in their ability about being able to provide equal quality of care were also much more welcoming than other physicians with an odds ratio of 3.53. Okay, now on to ADA understanding. So as you probably know, clinical practices fall under either ADA Title II, which is for public facilities, or Title III, which is private establishments that serve the public. And they must provide reasonable accommodations to people with disability. ADA Title II entities are legally required to give patients preferences, the primary consideration in the accommodation decisions. And Title III entities are encouraged to consult patients and emphasize their needs. So there's slightly different requirements of those two types of facilities. But the accommodation decisions for both types of facilities should always involve a collaborative discussion between clinicians and people with disability. So our main findings are that 36% of physicians report knowing little or nothing about their legal responsibilities under the ADA when caring for patients with disability. 71% of physicians do not know the correct approach to determining reasonable accommodations for people with disability. And 20% do not have the correct knowledge about who pays for reasonable accommodations for patients. So other related findings are that 68% of physicians report at least some risk of having an ADA lawsuit against their practice. 48% report that lack of time is a moderate or large barrier to caring for patients with disability. And 35% report that lack of formal education or training is a moderate or large barrier to caring for their patients with disability. So selected bivariable findings, younger physicians are a lot more likely than older physicians to know how to make accommodation decisions. Doctors reporting lack of training are much more likely than others to report an ADA lawsuit risk. Doctors who lack strong confidence in providing equal quality of care to people with disability are more likely than others to report little or no knowledge of the ADA. And doctors who lack strong confidence in providing equal quality of care to patients with disabilities are a lot more likely than others to report ADA lawsuit risk. And 61% of physicians who strongly welcomed people with disability reported some risk of lawsuits, compared with 78% of physicians who did not strongly welcome patients with disabilities. So if you don't strongly welcome patients with disability, it could be because you fear lawsuits. All right, so our study had important limitations. It was short. We aimed for 15 minutes. It was broad but shallow. We did not include questions that explicitly link physicians' attitudes with their treatment decisions for patients with disabilities. We had too few underrepresented minority physicians, as in the profession overall. The profession overall, especially for Black male physicians, is just embarrassing in terms of the numbers. So we could not explore their attitudes, and budgetary constraints limited our survey size. We could not compare across specialties, and we could not include other relevant specialties like physiatry, geriatrics, or pediatrics. However, the social desirability bias was not evident. The survey gave physicians the option to say that people with disability have the same or better quality of life than other people, But the fact that 82% said that people with disability have a worse quality of life suggests that physicians were strongly confident in their answer, that no one would argue with their response. And so this raises the questions about the care for people with disability, especially in times of scarce resources like the COVID pandemic that we were really, really fighting exactly a year ago right now. We were really worried about people with disability being denied scarce resources. And so how do we ensure that people with disability get equal quality of care? And the fact that only 41% of physicians feel confident in their ability to provide equal quality of care to people with disability. Well, we're coming up on 31 years after passage of the Americans with Disability Act. This is pretty troubling that only 41% of physicians feel that they can provide equal quality of care. And so clearly this must be addressed, but how quickly can that happen? And then finally, lack of knowledge about who makes accommodation decisions can put people with disability at risk. Physicians appear less likely to welcome people with disability if they fear lawsuits, and the lack of education and training is associated with lawsuit risks. So there's clearly still a lot of work to do. Okay, but why should patients with disability need to prove to their doctor that they value the quality of their life to get equal quality care? So I'd like to talk finally in my final section about the consequences of these attitudes. And here I'm going to tell you the story of Michael, and this is with Michael's permission. And Michael, as you can see here, is in a rehab power wheelchair that he operates. He cannot move any part of his body below his neck, and he operates the power wheelchair through the mini trackball with his chin. You can see that little cork trackball sticking out underneath his chin there. Okay, at the time we're talking about, Michael was 64 years old. He had a 21-year history of primary progressive multiple sclerosis, or PPMS. He was born in Birmingham, England. He's a smart guy. He has his doctor in philosophy or PhD in physics from Oxford University. And in fact, he worked at the particle collider outside of in CERN in Switzerland during his PhD work. And he got into high altitude cycling, long distance cycling. When he came to North America in 1981 for a postdoc at Cornell, he became an avid speed skater and cross country skier. And so he had just an incredible endurance athlete kind of body. But he was diagnosed with PPMS at age 42 and needed a wheelchair within 7 years and became quadriplegic and cannot move his body, as I said, volitionally below his neck. However, he's an avid wheelchair user. Within 3.5 years of active use, his wheelchair had 2,563 miles on it. And just for a point of reference, I've had my rehab power wheelchair for about 3 years, but I've got a whole bunch of scooters as well. So it's not really comparable. And mine only has about 1,070 miles on it, but I'm working on it. Okay, so Michael needed to get more PCA, personal care assistant services, than he could afford. And so he enrolled in a program called PACE, which is Program for All-Inclusive Care for the Elderly. It's a special program under Medicare for people who have both Medicare and Medicaid. You have to be considered nursing home certifiable by your state. You have to be at least age 55. Most members are transported from home to adult daycare and then returned to their family at night, and you must exclusively use PACE physicians. Some PACE leaders did not want Michael because he lives alone. They thought he should be in a nursing home given his level of disability, but there were some other people at that PACE who thought that they wanted him in their panel. And so he became a member of PACE, and it worked well. At the time, he had PCA coverage 10 hours a day, home nursing once a day. He did not attend PACE adult daycare. He preferred to be active in his community and, in fact, audited courses at the local university and went into town to go to museums and other things. Okay, so Michael's cancer number 1. In November 20, Michael developed new onset of bullous pemphigoid. Bullous pemphigoid is a very unusual skin condition where you get blisters that are like the size of a quarter or $50. Very itchy. It's, again, as I said, highly unusual. In March of 2015, he started complaining of loss of appetite, early satiety, in other words, he'd feel full pretty quickly, occasional vomiting and nausea, reduced food intake, and change in bowel patterns. His lower abdomen grew distended. He asked PACE repeatedly for gastroenterology evaluation, but the nurse practitioner, who was his designated gatekeeper, failed to schedule one. In May of 2015, Michael's blood pressure rose to 160 over 100 to 110, despite previously rock solid normal values. The hypertension was not controlled by medication. In June of 2015, he started having trouble saying more than several words before needing to take a breath. By early July of 2015, the PACE primary care physician visited Michael at home for the 6-month checkup the PACE doctors do. But he did not examine Michael, saying he could not get Michael out of his wheelchair. He did not even lift up Michael's shirt. And this slide shows you a picture of a rehab power wheelchair, which in fact can recline so patient can be supine. And in fact, my internist has sometimes examined me in my rehab power wheelchair with me kind of reclining in my wheelchair. And so that statement by Michael's PCP was completely erroneous. Okay, now for truth telling. This is Michael and me crossing the George Washington Bridge in New York City. And it is to kind of fess up that I am Michael's best friend. And I'm also his healthcare proxy. And so I knew all of this. And in fact, when Michael first told me in February that he was developing early satiety and the other problems that he was having, loss of appetite, I said, you know, Michael, the differential diagnosis of loss of appetite includes cancer. So you really need to kind of get on top of this. And I kept hearing his reports over the months and was pretty much going wild over them. But he really wanted to continue advocating for himself. And Michael and I were actually born 9 days apart. I was born in Boston. He was born in Birmingham, England. But because we were born 9 days apart, we've kind of spent our birthdays together for the last 11 years or so, except for pandemic. And so I went down in mid-July for Michael's birthday visit in 2015, and he looked haggard, unable to eat. He vomited even small amounts. We gave him a shrimp for his dinner his birthday dinner. He vomited that up. He had difficulty talking. He had a hugely distended lower abdomen and very, very swollen lower legs. And before I left the visit, I was terrified the entire time. I knew what was going on in my brain, but I said to Michael, can I have your permission now to actively advocate with your primary care? And so the following Friday, Michael had a CT scan. And over the weekend after the CT scan, he had a fever of 102 degrees. He couldn't eat. The visiting nurse prescribed Tylenol. As early on Monday morning as I thought would be okay, socially acceptable, I telephoned his PCP to find out the results of Friday's CT scan. And the primary care physician said, Lisa, you know, you better sit down. You need to be prepared for this. I knew what this was. And the guy said, it's a lower abdominal mass. And so I say, of course it is. I insisted that he be treated at a major academic medical center at a nearby city rather than their affiliated community hospital. And they agreed to do that. And so when he was admitted, he was found to have bilateral femoral vein clots, you know, the veins in your kind of groin area. And on July 30th, I took the train down from Boston. I got the 6 a.m. train, got to Philly at about noon, was able to get there for Michael's surgery to sign the informed consent forms. He had the surgery on July 30th. He had a 15-pound gastrointestinal stromal tumor removed and an IVC, inferior vena cava filter placed to prevent clots coming into his lungs from his bilateral femoral vein clots. His blood pressure fell to normal. That tumor had been resting on his aorta. His breathing returned to baseline pattern. That tumor had been pressing up on his diaphragm. He now takes daily imatinib, which is the drug for GIST. And fortunately, he's had no side effects, and 54 months later, he's tumor-free. So clearly, Michael got substandard care. But was there more going on? So Michael was in the hospital for 2 weeks. I came home to Boston, but then I went down again to be at his house for when he was brought back home by ambulance. His mother was going to come over to England to stay with him, but he couldn't be returned to an empty house. And so I needed to be there when he got home. And so over the next few days, I just very innocently asked questions and listened to the doctors and nurses. The home care nurse thought he was getting fat because he does not exercise. But was there diagnostic overshadowing? And that is a phrase that is used to mean that when people with disability come with a new symptom, the clinicians always think that whatever the new symptom is related somehow to the underlying disability. Okay, so MS does cause constipation. Maybe the doctors thought that Michael was really, really constipated. He looks 7 months pregnant. Was the abdominal distension caused by really a lot of stool? Doubt it. Severe MS can cause breathing problems, so maybe they thought he had end-stage MS, but there's no relationship between MS and hypertension or bullous pemphigoid. And it turns out that bullous pemphigoid is something that's called a paraneoplastic syndrome. And these are kind of unusual kind of health signs and symptoms that people can get. There are a whole range of different types of paraneoplastic syndromes that when somebody gets them, you kind of want to think, I need to be thinking about cancer in this person. Let me just keep an eye on them. It was finally the social worker who gave things away. The social worker admitted that palliation is PACE's goal. Michael's so very disabled that for Michael, their primary goal was palliation rather than active exploration and intervention as needed. However, I want to underscore that palliation is not equivalent to withdrawing care. Hopefully this attitude is rare, but maybe not. 5 years later, Michael is cancer-free and happy to be alive. And in fact, that picture of us on the GW Bridge was taken the following year for my birthday visit with him. And so that was the year after the cancer. But he did get COVID-19 in April 2020 from a home health aide and spent 3 ghastly weeks sick at home that I won't go into now. It's horrible. Cared for by 3 other home health aides who risked their lives to save him. And he has now recovered fully. So the bottom line, make no assumptions about people with disability, their abilities, their needs, their values, or their expectations, their quality of life. You need to really appreciate their own perceptions because you as a provider may have either explicit or implicit biases about disability. People with disability are generally very practical. They have to figure things out. And so just ask them about their goals, what they want for their care, and then work collaboratively with them to try to achieve their goals. And I always like to end with a picture of Independence Day. So let me stop there.
It's a wonderful presentation and what great news to finish it on.
Yes.
Just love it.
Yes.
That he's doing well.
Yes.
So we'll now open it up to any questions. Again, feel free to use chat or go ahead and unmute yourself if you have a question.
Thanks, Michelle.
I'll go ahead while we're waiting on people. What do you think, based on this experience in your surveys and your series of work, where do we start with identifying or developing interventions for our healthcare providers?
It's a really great question because a lot of people say, well, let's start by training new medical students and new healthcare professionals. Well, it takes 7 years from when you start training a new medical student to when they become an internist. I don't think we really have 7 years to wait because as I showed you on that slide, the number of people with disability is just increasing from year to year. And with the aging baby boomers, it's just going to skyrocket. So, basically what I'm saying now is that number one, we need to talk about it. We need to make a lot of noise about it. And I think that we need to think about whether continuing medical education needs to have some modules and some requirements about this. And I think that also, like everything under COVID, The COVID pandemic has brought to the fore a lot of concerns, especially around crisis standards of care, that have raised conversations about this. Some of this is still troubling, but I would welcome the rest of you who are out there, because I think it's going to be different in different parts of the nation about how we should try to be going about this.
Mhm. Mhm. Good point.
Leslie, there's a couple messages in the chat. I'm happy to read them if that's helpful.
Oh, please do. Please do.
Okay. Portland says, sounds like there is a lot of intersection between ableism and fat phobia in medical care, similar to assumptions that any new issues are a result of the disability. Many fat studies show a similar phenomena that many medical professionals assume one's fatness is the source point of health issues, even when that ends up not being the case. What can these intersections tell us about how non-normative bodies/minds are viewed within the healthcare field?
Well, in fact, I believe that uh, excess weight is one of the most common reasons for disability, but it's also it's complicated. The causality is very, very complicated. And one of the things that we found is that in our individual interviews with doctors and our focus group interviews with doctors is that they have a lot of prejudice and a lot of stigmatization and a lot of ableist attitudes about people with obesity. I'll just use that terminology. And they also, with their inaccessible equipment, usually I feel like I've done so many interviews, I've heard it all, but no. We did a focus group with rural healthcare physicians, and they told us that they did not have wheelchair accessible weight scales in their offices. And so one physician sent his patients who were wheelchair users or too obese to stand on the scale to granary storage areas or to meat processing plants to get their weights done. And so you can just imagine, how that makes people with disability feel, how that makes people with obesity feel. So it's still really, really a huge problem. It's a huge problem. Um, Tons of stigmatization and ableism. I agree with that comment 100%.
Wow.
Yeah, I know the granaries and the cattle processing plants. I just
Mm-mm.
really.
Yeah.
And, the thing is, in focus groups, they say this without even, their faces don't even change. They're just saying it as a matter of fact kind of thing. Like everybody's going to say, that's okay.
Related to your point about stigma, Elizabeth asks in the chat, what changes need to occur in medical curriculums to increase knowledge about and competence in the treatment of individuals with disability/stigmatized body? Not how well do current models of training help, but if you had the power to decide what training would exist, what would that be?
There is a very slender literature. It's small, but it suggests that if trainees go out and hang out with people with disability and just get to know them as people and realize that they're just like other people, that they suddenly become less biased. They have less implicit bias. They have less stigmatization. I think it's also a good idea for trainees to take the implicit association test, the online implicit association test that people take for race and ethnicity. There's a version of it for disability. It's actually, ironically, somewhat ableist because you need to, have good hand-eye coordination to be able to do the implicit association test. So it's a little bit of an ableist test, which is ironic. But I still think that if you can do it, just opening up your own mind to the fact that you might in fact have your own implicit biases, that could be helpful. But I think, finding a center for independent living and just seeing whether they'd be willing to have a beer with you on a Friday afternoon. People there, or, just getting people together in a way that wouldn't be stilted. And so you'd have to think about it. You'd have to figure out how this is going to work. But I think just in a informal sort of way, just trying to get people to be familiar with the lives of people with disability and also including disability in the social history. The New England Journal of Medicine in 2014 published a list of kinds of questions that you should ask in the social history And I recently went back and reviewed, and they're great questions. You know, they're social determinants of health type questions, but there is not a single question about disability in the social, history. And so I think that just beginning to add those kind of questions, about technologies, about accessibility of homes, et cetera, it would be important.
A lot of people are echoing your thoughts on those suggestions. One other person said, "Thank you for sharing your personal experience with your friend, and she's happy to hear that he has recovered. Something that she has noticed is that many doctors will tell her providers that the person has lived past their life expectancy, and therefore they are reluctant to use more intrusive interventions. Have you had any experience with that issue?"
That is so interesting that you would say that, because I know we just got like a minute left, but after the Health Affairs article about quality of life came out, I got all these requests to do all these kind of webinars, get-togethers online, Zoom meetings. One of them was from a group called IMALS, I am amyotrophic lateral sclerosis, or Lou Gehrig's disease. It was founded by a man who graduated from Yale and in his late 30s developed ALS. And it's a supportive group for people with ALS to get together and figure out how to advocate for themselves. And the guy who invited me self-identified as a 50-ish-year-old physician who had been diagnosed with ALS. It was slowly progressive, but he uses a wheelchair. And he confessed that reading our article was the first time he thought, uh-oh, maybe what's happening with me is because my physicians have a bias about disability. And what had been happening to him. And when I did this 90-minute kind of webinar with the IMALS group, other people said the same thing, that they would come with a new symptom to their doctor. And their doctor would say, and the median survival for people newly diagnosed with ALS, if you forget people like Stephen Hawking and the guy that had invited me, the median survival is 3 years. And so there were doctors would say to them, well, I'm not going to bother to work this up because you've only got 3 years left to live. And so this man who invited me self-identified as having diverticulitis, which can be easily treated or hopefully treated. And he needed it treated because it was affecting his ability to eat and his comfort. But the doctor had not taken the steps to do that because he, in the doctor's view, had such a short time left to live. So that's kind of a downer place to end. And you're about to start your summers. But thank you for having me, Leslie. I enjoyed having had a chance to talk to all of you today.
Well, thank you for your time, and just the chats going crazy. Everyone's saying thank you, and we really appreciate your.
Well, thank you. I'm really delighted to have a chance to share these stories with you. This is how we learn, is by telling each other's stories.
And you do it very well. You do it in a narrative format. You bring us in and connect us to what you've learned. So thank you for that.
Thank you. And thank you, everybody. Bye.
Have a nice summer. We'll talk to you soon.
Okay, bye-bye.
Bye-bye. Bye, everyone.
Bye, everybody.